So we'll get started. So if you look at the ABIM content specification, allergy and immunology comprises about 2% of the boards. This is in comparison to other specialties like dermatology, which is 3%, endocrine 9%, hematology 6%, neurology 4%, and renal 6%. So although 2% doesn't seem like a lot, but in actuality, it's a lot of actually a lot of questions, and it also really pertains to your daily practice as well too. So this is kind of an outline for what we're going to go over today. We're going to first talk about hypersensitivity reactions, different gel and Coombs type 1 through 4. We're going to talk about the most dangerous of the type 1 reaction, which is anaphylaxis or anaphylactoid reactions. We'll talk about urticaria, eczema, contact dermatitis, rhinosinusitis, basically the sort of bread and butter common topics that you'll see in your daily practice and also see on your ABIM boards as well too. I'll touch very briefly on asthma because I think a lot of that is covered in the pulmonary section. We'll talk about drug allergies, insect allergy, food allergies, and I'll touch a little bit about immunodeficiencies because although it's congenital immunodeficiencies, a lot of those patients are actually growing up, and you're likely to see them in your daily practice because we've advanced so far that now they're living up well into adulthood and beyond. And then we'll finally finish with angioedema. So first, let's talk about hypersensitivity reactions. And probably the key thing about hypersensitivity reactions when you're listening a history from your patient is to get the timing of the reaction. That is really, really important. I can't stress that enough. When I get consultations from the emergency room or urgent care or other primary care providers, I always ask, how long after they, ate something or got a sting or whatever, or taken a particular drug, did they develop symptoms, right? Because the timing really affects which type of allergic reaction these things sort of fall into. And we'll talk more about that. So the first type is your type 1 immediate hypersensitive reaction. This is IgE mediated. And the onset is within minutes, pretty much right away, with at most 2 hours after the initial event. Your type 2 reactions or cytotoxic reactions are IgM or IgG mediated, and these take about a few days, all right? Your type 3 immune complex reactions or antibody-antigen complexes that form, and these take a little bit longer. They take weeks to sort of develop after the initial trigger. And then finally, there's the type 4 reaction, which is the delayed reaction. And these are T-cell mediated, so they take about 48 to 96 hours to manifest. All right, so remember those key time frames. That'll give you clues to which type of reaction it is, and it'll give you clues as to, obviously, what the right answer is on the ABIM boards. All right, so first let's talk about type 1 immediate hypersensitive reactions. Again, this occurs right away, minutes to at most 2 hours after the initial trigger. It's Ig mediated, so these are things that you can think of that are sort of classic allergies, your hives, your allergic rhinitis, your asthma, food allergies, latex allergies. And there's really two phases of this. There's the acute phase, which is right away, and the later phase, okay? So the acute phase occurs right away. It occurs within minutes, okay? And what happens is you've already got preformed Ig antibodies that bind to the antigen, okay? And when the Ig antibodies bind to the antigen, it causes them to bind to receptors on your mast cells, and your mast cells basically just release all of their contents out. And this process called mast cell degranulation causes release of mediators such as histamine, leukotrienes, prostaglandins, and cytokines that are responsible for reactions that you see, okay? So the major player is really histamine, and that causes the wheal and flare reactions that you see, i.e. the hives, the angioedema, the bronchoconstriction, the itchiness, the pruritus, and there's also H2 receptors on your skin and also in your gastric tract that increases gastric acid secretion. Now there's a late phase. So the late phase occurs about 3 to 12 hours after the acute phase, okay? And that's why some of these reactions can last for days, although their onset is within a few minutes. Because after the mast cell releases the cytokines, other immune cells kind of migrate into the area. Those immune cells include eosinophils and basophils. And those eosinophils and basophils then release their own mediators, and that sort of continues on the reaction. So you can have a reaction that starts right away, but can persist for up to a couple days afterwards because of the late phase reaction. Okay? Now let's talk about anaphylaxis. Anaphylaxis is really the life-threatening Ig-mediated reaction that we all should know about and be concerned about because it's potentially fatal. So common causes of anaphylaxis include antibiotics, penicillin, cephalosporins, foods, as you all know, peanuts, tree nuts, shellfish, latex can cause anaphylaxis. There are populations that are susceptible to allergic reactions from latex. These include healthcare workers, like all of us in the room, patients with spina bifida, or patients who've had urogenital malformations or multiple surgeries are more susceptible to latex allergic reactions. And then there's also anesthetic agents that are known to cause allergic reactions and anaphylaxis. These include induction agents, neuromuscular blocking agents, and so forth used during surgery. And then finally, insect stings are a common cause of anaphylaxis as well, too, typically like bee stings. Okay? So how do you make the diagnosis of anaphylaxis? And so number one, you could have sudden onset of involvement of the skin and either sudden respiratory symptoms or hypotension, okay? Or number two, and this is where people really get confused because people don't recognize symptoms of anaphylaxis because you only have these two things that occur outside of, that don't include hypotension. So you can have anaphylaxis when you have skin or mucosal involvement or respiratory involvement, hypotension, or GI symptoms. So what does that mean? That means that if someone comes in and has symptoms of just, for example, a skin rash and GI symptoms, that's still considered anaphylaxis. You don't have to have hypotension before you call it anaphylaxis. So this is where I talk to a lot of ED physicians and urgent care physicians where the diagnosis of anaphylaxis is often missed because they're expecting, or people are expecting, hypotension. And that's not true. You only need two organ systems to be affected to call it anaphylaxis, and you need to treat that right away, okay? So just because the patient doesn't have hypotension doesn't mean they don't have anaphylaxis going on. Hypotension actually is the last thing to go, right? Because when you have a severe allergic reaction, your body actually naturally compensates, right? There's an autoregulatory mechanism to compensate for that hypotension. And hypotension only occurs when your body's unable to compensate, right, any longer, and that's when you have hypotension. So it's really important to understand and make the diagnosis of anaphylaxis as soon as possible. And then lastly, any kind of hypotension that occurs after exposure to a known antigen is considered anaphylaxis. What about anaphylactoid reactions? What does that mean? Well, anaphylactoid reactions are actually clinically indistinguishable from anaphylactic reactions. And actually, anaphylactoid reactions are now called non-IgE-mediated anaphylaxis, okay? I still use the term anaphylactoid because that's kind of in the literature still, and that's what people still know and kind of remember the name. But really, the actual correct name is non-IgE-mediated anaphylaxis because you can't clinically distinguish between the two, right? So what's the difference? Well, the difference is these reactions are caused by direct mast cell degranulation. So you don't need IgE in order for these mast cells to degranulate and release all of their contents, right? So these certain things can cause direct mast cell degranulation. These include, for example, aspirin anaphylaxis, opioid anaphylaxis, radiocontrast anaphylaxis, or sulfite anaphylaxis. So both anaphylaxis and anaphylactoid occurs because they're immediate reactions. They occur within minutes, right, to 2 hours after antigen exposure. Have a multitude of symptoms, cutaneous being the most common, okay, about 90% of the time, okay? But just because you don't have cutaneous symptoms does not mean that you can rule out anaphylaxis, because 10% of the time you may not have cutaneous symptoms. You do have respiratory symptoms about 50% of the time. That includes things like wheezing, shortness of breath, throat tightness. Cardiac symptoms occur about 30% of the time, and that includes hypotension, dizziness, syncope. And again, the really important point is lack of hypotension does not rule out anaphylaxis or anaphylactoid reactions. 25% of the time you'll have GI symptoms. These include abdominal pain, nausea, and vomiting. Okay. So what is the treatment for anaphylaxis or anaphylactoid reactions? It's epinephrine, epinephrine, epinephrine. All right, so that's a key thing that you have to remember. And when they did studies on why people died from anaphylaxis, there were two main compelling reasons. One was failure to recognize anaphylaxis, i.e. people thought, oh, because this patient did not have hypotension, this was not anaphylaxis, and they waited until finally the patient crashed, and the patient ultimately had a fatality, unfortunately. The second reason is, failure to give epinephrine early treatment of anaphylaxis. So those two things, one, failure to recognize anaphylaxis, and two, failure to give appropriate treatment, i.e. with epinephrine right away. A lot of times people think, oh, well, we'll give prednisone or something like that, or antihistamines. No, that's not the first-line treatment, first-line treatment for anaphylaxis. It's epinephrine, 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 right? Antihistamines are not going to help with other symptoms like bronchoconstriction or hypotension. Prednisone or systemic steroids don't take effect until about 6 to 8 hours later, so it's way, way too late. So the first thing you got to think of when a patient is having anaphylaxis is epinephrine, 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 okay? And the dose is anywhere from 0.2 to 0.5 mLs of a 1 to 1,000 dilution intramuscularly in the anterolateral thigh, okay? The adrenaline autoinjector that you could prescribed for patients is 0.3 mLs, and that's also administered intramuscularly. How does epinephrine help with anaphylaxis? Well, it has alpha and beta adrenergic effects, which causes bronchial relaxation, vasoconstriction, and also decreased vascular permeability. So it really counteracts all of the things that occur with anaphylaxis or anaphylactoid reactions. Okay. What about patients on beta blockers? What do you do with those patients? Well, patients who are on beta blockers are beta blockers are relatively contraindicated in patients who are at high risk for anaphylaxis. So, for example, if you have a patient who is a beekeeper and has a bee allergy, right? You don't want to start this patient on a atenolol or metoprolol, right? Because it won't make it will increase their risk of a systemic reaction to a bee sting, and also two, it will negate some of the effects of epinephrine, right? So that's not a good choice. You want to try something else, another antihypertensive agent like amlodipine, for example, or hydrochlorothiazide or something else, but not a beta blocker. So, but if a patient is already on a beta blocker, for example, and for whatever reason develops an anaphylactic reaction, what is the first-line therapy? It's still epinephrine. You still give it first, and if that doesn't work, then the next line would be glucagon for patients who are on beta blockers who are non-responsive to epinephrine, okay? And the reason why you can give glucagon is it exerts effects independent of the beta receptors, so you can give glucagon, but only after you've administered epinephrine. So the treatment for anaphylaxis, same thing with all other emergencies, is ABCDs, all right? Airway, you can give them inhaled albuterol for bronchoconstriction, i.e. wheezing symptoms, intubation if needed if they have severe laryngeal edema, circulation, volume resuscitation for severe hypotension, okay? And drugs, again, epinephrine is always first line. Supplementary medications include H1 and H2 antagonists, and then steroids may prevent the late phase reaction, but those two things are not first line. It's epinephrine, epinephrine. Type 2 cytotoxic reactions. The type 2 cytotoxic reactions occurs days after the initial onset, okay? And what happens is you've got IgM and Ig antibodies, and they bind to fixed tissue antigens or to cell receptors. And when you have this binding of antibodies, it causes target cell destruction via complement activation, opsonation from production of C3b, or you also can have phagocytes that attack these antibody-coated cells. So examples of these include fixed tissue antigen disease, for example, Goodpasture's, where the antibodies are attached to the basement membrane, myasthenia gravis, where antibodies are found to attack the acetylcholine receptors on muscle cells. And then you've also got target cell receptor antibodies, for example, with autoimmune thrombocytopenia, Of course, the target is platelets, hemolytic anemia, the target are red blood cells, and finally leukopenia, autoimmune leukopenias, where the target is white blood cells. Your type 3 immune complex reaction occurs weeks, usually 1 to 3 weeks after the initial antigen exposure. So whenever you hear type 3 or immune complex reactions, think about vasculitis. All right? This occurs when immune complexes form and you have antibodies that combine with antigen. These immune complexes start to precipitate and they deposit in organs and small vessels, causing the vasculitis component that you see. This activates complement, a whole inflammatory cascade, and what you have is a leukoclastic vasculitis that occurs. You also have immune complex deposition of the organ systems like your kidneys, so you have glomerulonephritis in your joint spaces. That's why you have the arthritis as well too, and on your skin. Examples of immune complex reaction include serum sickness, which is a systemic reaction. This occurs when a large amount of antigen is injected to a non-immunized animal. And you also got the arthritis reaction. It's a localized reaction where a hyperimmunized animal is given an injection of antigen, and you have a lot of Ig antibodies, and these immune complexes start to form in this kind of local reaction. For your type 4 delayed reaction, these reactions occur 24 to 96 hours after, and it's caused by sensitized T cells that interact with antigen. So examples of these reactions include your contact dermatitis and tuberculin sensitivity. Okay, so think about what happens when you order a PPD for one of your patients, right? What happens is the tuberculin protein gets injected into the skin. That protein is taken up by what we call antigen-presenting cells. It's taken up and then moved and migrated to your lymph nodes. In your lymph nodes, you've got T cells, and if they're previously sensitized, they'll mount a reaction to it. And that's when you start seeing that bump that you see with the tuberculin reaction. And of course, that bump occurs when? 48 to 96 hours later, when you have the patients come back for a check. So when you think about delayed reactions, think about what happens with your PPD reaction, okay? Contact dermatitis is another example of a delayed reaction that occurs with like drugs, for example, like neomycin, topical antibiotics. Patient puts on neomycin. A couple days later, they come back with kind of like this rash and where they put on the neomycin. Next, we're going to move on and talk about urticaria, or hives, okay? And you can kind of divide urticaria into acute versus chronic. Acute urticaria, by definition, is hives that last less than 6 weeks. Examples of this include foods, drugs, pollens, insect stings. And then you also have chronic hives, right? And this occurs when you have hives that last more than 6 weeks, pretty much on a daily basis or every other day basis. Now, 90% of chronic hives is idiopathic, all right? So we don't really know the underlying cause of it despite extensive evaluation. So a lot of times it's just about reassurance. Of the causes that are identified, about 10%, some patients can have thyroid disease, autoimmune disease, malignancy, or chronic infection. But the history would kind of tell you, which one of these it is. And usually they already have the diagnosis in hand, and then they'll get the chronic urticaria, rather than it's kind of like a subtle, indolent, malignancy or something like that, and they present to you with chronic urticaria. In terms of treatment, you want to use non-sedating antihistamines as first-line therapy. Dermatographism is kind of an interesting phenomenon, and sometimes goes along with chronic urticaria. Basically what it means is just writing on the skin. Dermato is skin, and graphism is like graffiti writing. And basically what happens is you get this sort of exaggerated wheal and flare that occurs after the skin is stroked or gentle pressure is applied. So you actually can write things on people's arms or legs when they have this phenomenon of dermatographism. There's also physical urticarias, which is really interesting. So some people can get hives just because it's cold or just because it's hot. So you can have something called acquired cold urticaria, where when the patient is exposed to cold weather, they start to develop hives. And sometimes even swelling as well, to angioedema as well too. So for these patients, you tell them, don't go swimming in the ocean. They can have actually like full-blown anaphylaxis because of that. And the testing is you can put what's called a 5-minute ice cube challenge. You put an ice cube on their forearm for 5 minutes, and then you'll actually see on the rewarming phase, after the ice cube is removed, sort of hives to start to actually develop where you put the cold. And sometimes it occurs in different parts of the body as well too. So very interesting. And then you've got the opposite, which is cholinergic urticaria, and this is precipitated by heat. So these patients are quote-unquote allergic to heat. So they'll actually get hives when they take hot showers, it's a hot day, they exercise, and they get this really kind of very small, very itchy kind of punctate hives that occur on their arms and legs. Now, one thing that you want to remember is to know red flags. So all the other ones are kind of benign, but one thing that's not benign is urticarial vasculitis, and really it's an autoimmune disease. And so when someone comes in with chronic hives, for example, you want to rule out some of the red flags. And you want to rule out it's not urticarial vasculitis. So with urticarial vasculitis, the distinction is that these lesions last more than 24 hours in a fixed location, so these hives don't go away, in contrast to your chronic urticarias where you have the hive, it'll go away, then it'll kind of migrate to a different place, but it won't stay at the same location for more than 24 hours, okay? With urticarial vasculitis, those hives stay for days, okay? And also you get these other things. You get ecchymosis, you get purpura, you get petechiae, kind of other skin findings that you don't get with chronic urticaria. The hives are typically described by patients as non-paritic. They burn and they're painful, right? So that's a common distinction between the two. And then finally, they also have constitutional symptoms, like they'll have fevers associated with this, arthritis, night sweats, weight loss, malaise, fatigue. So those are kind of the red flags that you want to elicit from patients. And if that's the case, then you want to send them to dermatology for a skin biopsy to rule out urticarial vasculitis. With labs, a lot of times you'll see a decreased C3 and C4 level. Again, because it's an immune complex kind of related disease, you have low levels of C3 and C4 because of complement consumption. And you have also antibodies to C1q. Now, angioedema. Angioedema is a sudden temporary edema within a localized area, and those areas typically involve either the lips, the face, the hands, the feet, or the larynx. Basically areas that are very vascular, you'll see that. And there's type 1 immediate hypersensitivity reactions, things I mentioned before, food allergic reactions, insect stings, drug allergy, latex allergy, and so on. You also have something interesting, which is ACE inhibitor-induced angioedema. You probably have seen it in your offices. Now, the interesting about ACE inhibitor-induced angioedema is that it can occur any time after the patient has started an ACE inhibitor, right? So they can actually come in 6 months later, 9 months later, all of a sudden have swelling of their lips and swelling of their hands. And the first thing to do is just to discontinue the ACE inhibitor without any additional workup, okay? The other thing to keep in mind is that even after you remove the ACE inhibitor, the angioedema can actually continue for another 4 weeks or so. So you just tell them reassurance, and then if it lasts more than 4 weeks, then you can refer for additional evaluation and workup. ACE inhibitor-induced angioedema occurs about 0.1 to 0.7% of the population, but it's more common in African Americans, right? So think about ACE inhibitor angioedema. It's very common because a lot of patients are on ACE inhibitors these days for a variety of different reasons, hypertension, diabetes, and so forth. So we're seeing it a lot more. So the first thing to do, just discontinue the ACE inhibitor. Now, hereditary angioedema is a congenital angioedema, and this is due to a defect in C1 esterase inhibitor function. This is an autosomal dominant condition. So there's two types. There's a type 1 and a type 2. Type 1 occurs when you have low levels of C1 inhibitor protein, okay? Type 2 occurs when you have normal levels of C1 inhibitor protein, but that protein is non-functioning. So therefore, you have normal levels, but you still get this condition because the protein isn't functioning. So what do these patients get? Well, they get recurrent episodes of angioedema, abdominal pain, extremity swelling, and laryngeal edema. And a lot of times they'll get really severe abdominal pain where they have multiple exploratory surgeries, because they have such severe abdominal pain and they don't find anything. And typically this condition starts to manifest right around puberty for whatever reason, okay? So they'll start at puberty, maybe get some surgeries, and then you'll kind of see them as adults. So you want to think about this condition when they have recurrent episodes of angioedema. Now, the interesting thing about this condition is that you don't get urticaria with it, okay? So if a patient comes in with urticaria and angioedema, it is not hereditary angioedema. You cannot have urticaria with hereditary angioedema, okay? You may have something called erythema marginatum, which is kind of a serpentitious rash that sometimes they get, but they don't get the urticaria, okay? So if they have urticaria, it's not hereditary angioedema. How do you make the diagnosis? You can screen with a C4 level, and typically these patients will have a low C4 level, especially when they're having attacks. And then you can also, of course, check for C1 esterase level and also function as well, too, to differentiate between type 1 and type 2 hereditary angioedema. How do you treat? We didn't have a lot of options before, like maybe 5-10 years ago. All we had were attenuated androgens, which came with a lot of side effects, caproic acid, which had, again, even more side effects than the attenuated androgens. But now we've actually got plasma-derived C1 esterase inhibitor protein, which patients can get as an infusion to replace the C1 esterase protein that they're missing. So that's one thing we could do. We also have something called bradykinin receptor antagonists and also kallikrein inhibitors that we can give these patients. So a lot has happened within the past 10 years in terms of treating these patients, fortunately. All right, next topic we're going to talk about is eczema. It occurs more often than children, but adults still see them as well, too, for sure. It occurs in about 1 to 3% of adults, and as you all know, presents as a kind of dry, red, scaly, very itchy type of rash. Now, one thing you want to remember is if a patient has adult onset eczema that's refractory to conventional therapy, you want to think about cutaneous T-cell lymphoma or mycosis fungoides, okay? If it's all of a sudden occurring in your 60-year-old where they never had it before and you tried a lot of different things and it's still occurring, you want to keep that in the back of your head that it's a possible T-cell lymphoma. So how do you treat? Well, you treat by sort of this kind of layered approach, this kind of pyramid. The main thing to remember is you want to moisturize these patients, okay? You want to really, really moisturize the skin because a lot of these patients have what's called an impaired permeability to water. So they lose a lot of water from their skin, so you have to replenish that moisture. So the aggressive use of emollients is really key for these patients. Next are immunosuppressants. These include your topical corticosteroids and your FK506 inhibitors, pimecrolimus or tacrolimus. Topical corticosteroids are first-line treatment. Ointments, topical corticosteroid ointments have better bioavailability than your creams. However, ointments can be very occlusive, so when it gets really hot, it actually may cause more itching and folliculitis. So creams may be better tolerated when it's really hot. One thing to note is chronic use of high-potency topical steroids can cause skin atrophy. So you don't want to use high potency or even medium potency in certain areas of the body, for example, the face for a long time, kind of more sensitive areas like the axillary area and also the groin area as well, too. Topical calcineurin inhibitors, what they do is they bind to something called the 5K506 binding protein, and this causes inhibition of gene transcription of various inflammatory cytokines. So that decreases the inflammation in the skin. And examples of that, as I mentioned, are tacrolimus or pimecrolimus. And with these, they don't cause the skin atrophy. Kind of the barrier to these things are they're a little more expensive than the topical corticosteroids. Next are antihistamines in your chain of treatment. What antihistamines do is they kind of break the itch-scratch cycle. So if patients are having this kind of terrible, pruritus, and they keep on scratching, that causes more inflammation, When you have more inflammation, it gets even more itchy, and you kind of run into kind of this vicious cycle. So you have to try to break that cycle. So what you can do is you can give them H1 and H2 blockers. The first generation antihistamines are more effective than the newer ones. However, they have sedative effects and also anticholinergic effects. You want to avoid them, particularly in the elderly. Okay. You want to also avoid topical antihistamines because there's a potential for sensitization when you do, topical antihistamines like topical diphenhydramine. Wet wraps are really kind of a last option. It's not very comfortable for a lot of people, but it does help. It reduces trauma because it acts as a barrier. It kind of cools the skin and also improves the penetration of your topical steroids and also your topical calcineurin inhibitors and also your emollients as well too. And then finally, as a last resort, some patients have superinfection, and so you can do topical or systemic antibiotics for these patients as kind of a last line therapy. There's research that shows that a lot of patients have Staph aureus colonized on their skin. About 90% of atopic derm patients have colonization in their skin versus only 5% in normal subjects. And about 50% of those patients, the Staph aureus actually produces a toxin actually called TSST, which causes inflammation in the skin. So by treating the Staph aureus infection, you decrease the inflammation and hence you improve the eczema. You can use either systemic with antibiotics with a first generation cephalosporin, or you can also use topical antibiotics as well too if there's just local involvement. You don't want to keep them on it for a long period of time because then you start to develop resistance and then you start having MRSA colonization. So brief periods of treatment if the skin looks infected to you. Okay. And again, this is kind of the last resort in the chain. You want to try all the other things that I presented in the pyramid first before you go on to antibiotics. Okay. Next, I'm going to talk about contact dermatitis. Right. So again, contact dermatitis is a type 4 delayed hypersensitivity reaction. It's T-cell mediated. Onset is 48 to 96 hours after the trigger. Common causes include poison oak, poison ivy. You can also have metal allergy as well too, chemical allergy like nickel, rubber, hair products, and makeup. And you can do what's called patch testing on their back if you suspect a chemical or a metal allergy. Okay. Rhinitis. All right, so we'll move on to rhinitis. There's different types of rhinitis. There's an allergic rhinitis, non-allergic rhinitis, eosinophilia syndrome, vasomotor rhinitis, rhinitis medicamentosa, and atrophic rhinitis, and we'll kind of go over each of one of these entities. So with allergic rhinitis, you can have seasonal, okay? So seasonal includes, patients that are allergic to grass, trees, weeds, and pollens, okay? And so, grass tends to pollinate in the spring, trees tend to pollinate in the summer, and weeds tend to pollinate in the fall, okay? So you kind of get an idea of what their symptoms are based on the timing of their symptoms. And you've got also year-round allergens as well, too, like dust mites, molds, and animal dander. And then lastly, you kind of have patients who have year-round symptoms with seasonal exacerbation because they're allergic to kind of everything. Patients will have symptoms like congestion, runny nose, sneezing, nasopritis, things that you all see in your offices. This is all IG mediated, and that's why when you do nasal smears, you'll find eosinophilia. Right. So what's the treatment? It's a AAA. You want avoidance, okay? So you can send them to the allergy to do skin testing, or you can order RAS to determine what they're actually allergic to. And then number 2, antihistamines are first-line therapy, but nasal and corticosteroids are most effective. And then we can offer them allergen-specific immunotherapy or allergy shots in the allergy office. So when you do skin testing, you can let them know about avoidance, right? So if they've got a lot of allergies to trees, which pollinate during the spring, then they want to close their windows and maybe stay inside during the spring, maybe start their medications early before the spring season starts. Grasses start to pollinate in the summer, weeds in the fall. You can also tell them to get home air filtration systems to remove some of those pollens as well too.
If they're allergic to dust mites, you want to tell them to purchase mattress covers and pillow covers. You want to decrease the humidity in the home to less than 50% because dust mites kind of really thrive with high humidity. And then you want to tell your patients to wash their sheets in hot water, 140 degrees, each week to kill off the dust mites. Removal of the pet, this is a tricky one. Whenever I tell my patients to remove their pets, they're more likely to get rid of me than get rid of their dogs. So I don't even talk about that subject. But I tell them at least, keep, your dog, your cat at least out of the bedroom, okay? At a very minimum, get an air filtration system to remove some of that dog or cat dander, okay? Antihistamines, all right. Again, just to kind of note, avoiding the elderly, your first-generation antihistamines like diphenhydramine, chlorpheniramine, or hydroxyzine. These antihistamines tend to cross the blood-brain barrier, and they interact with dopamine, serotonin, and acetylcholine receptors. And so you get a lot of anticholinergic effects for especially elderly patients. So, blurry vision, dry mouth, urinary retention. Definitely don't want to start your elderly patient with BPH on one of these, first-generation antihistamines. Second-generation antihistamines are a better option. They're less likely to cross the blood-brain barrier. Cetirizine, fexofenadine, and loratadine, desloratadine, they cause little to no sedation. Allergy immunotherapy, these are commonly known as allergy shots. They only work for Ig-mediated conditions. So what we do is we give increasing doses of allergens via the subcutaneous route to induce immune tolerance to allergens. And so what it does, it increases what we call T regulatory cells. It increases suppressive cytokines such as IL-10 and TGF-beta and things like that to kind of block off the immune response to these aero allergens. Nares, or non-allergic rhinitis of eosinophilic syndrome, or Nares, it is a condition where you have chronic nasal congestion. The nasal smear will show eosinophils, but when you do skin testing or blood testing, allergy testing, they don't demonstrate any sensitization. Okay. Vasomotor rhinitis. So this is a pure reaction to neurogenic or vagal stimuli. So patients will complain that they get, drippy nose or sneezing attacks when they eat spicy foods or certain foods, or they're exposed to cold or sunlight. And so you kind of reassure them, it doesn't mean that you're allergic to that food. It's just a vasomotor rhinitis that's occurring. Rhinitis medicamentosa is a rebound congestion that occurs when patients overuse vasoconstricting nasal drops like phenylephrine, oxymetazoline, and anaphazolin. And what happens is they actually get addicted to these things. And I have patients who come in with like 6 bottles of anaphazolin in their pockets, and that's when you know they're really addicted because they're just squirting it like all day long, basically, and they can't breathe unless they do it. So really hard to get off. So you want to tell your patients, don't use these things for more than 3 days, or just don't use them at all, okay? Because you can have that addictive potential, and it's hard to get them off. Sometimes I have to start them not only intranasal corticosteroids, but systemic steroids in order for them to get off of these vasoconstricting nasal drops. Rhinitis in pregnancy, this is probably fair game for the boards. They love questions regarding pregnancy. You have something called pregnancy rhinitis, which occurs within the last 6 weeks of pregnancy. So a question will, kind of include things. What can you do for these patients? So just note that there are certain medications that are Class B in pregnancy. So budesonide intranasal spray is Class B in pregnancy. Cetirizine, loratadine, cromolyn, montelukast is Class B in pregnancy. So safe to use in pregnancy. You want to avoid any kind of oral decongestants, okay, like phenylephrine. Why? Because they increase the risk of congenital malformations like gastroschisis and also intestinal atresia. So that's a no-no. You want to avoid those things and advise your patients to avoid those things. Now, rhinosinusitis. Now, this term has kind of come into play recently because before we kind of separate into rhinitis and sinusitis, now we know that it's really one airway, and whatever happens in the nose kind of gets extended into the sinuses as well, too, so hence the term rhinosinusitis. And it's kind of divided up into acute versus chronic. Acute meaning that symptoms have been occurring for the past 4 weeks, whereas with chronic rhinosinusitis, symptoms have been occurring for more than 12 weeks. Okay. So these patients will come into your office, runny nose, nasal congestion, sometimes facial pain, sinus tenderness. Now, the key thing to know is that the vast majority of these symptoms of acute rhinosinusitis is viral in etiology. They are not bacterial. A very, very, very small, less than 2% are actual bacteria. So you don't need to give these patients antibiotics. And you actually don't need to order routinely sinus CTs or sinus x-rays because you can't distinguish between bacterial versus viruses as the etiology for acute sinusitis, okay? Bacterial sinusitis is a clinical diagnosis. It is not a radiographic diagnosis, okay? So when do you give antibiotics? Well, there's very clear criteria according to the Infectious Disease Society of America that tells you when you should give antibiotics for suspicion of bacterial sinusitis. So there's 3 criteria essentially. One is if the patient has severe symptoms, right? They have high fever, come in like first day, high fevers, purulent nasal discharge, and facial pain, right? That's when you give antibiotics. Second criteria, or if they've had worsening of symptoms after initial improvement. So they kind of got better, and then after about 5 days, they got worse again, this sort of double sickening, okay? That's when you should give antibiotics. Otherwise, you don't need to give antibiotics. And then finally, persistent symptoms. If they've had persistent symptoms for more than 10 days, it's not getting better, then that's when you should think about bacterial sinusitis and give them antibiotics. But for all the other patients who come in, I've had this sinus thing for 3 days and that's it, it's not going to be bacterial. It's going to be viral in etiology, okay? So if they fit these 3 criteria, then what's the first line in terms of treatment? It's amoxicillin versus clavulanic acid. If they're allergic to penicillin, then you can also give them doxycycline as well too. Now, chronic rhinosinusitis, as I mentioned, are symptoms that occur more than 12 weeks. So these patients have mucopurulent discharge, obstruction, nasal congestion, sinus pressure, sometimes even loss of smell and taste after a while, right? So CT, you'll see like mucosal thickening, maybe even some air fluid levels sometimes. If you do rhinoscopy, you'll see mucopurulent discharge in the osteomeatal complex. Treatment, intranasal steroids, and saline lavage to restore the osteomeatal patency, right? Because what happens is your sinuses are actually connected to your nasal cavity through the osteomeatal complex. So when you get inflammation, that osteomeatal complex closes, and so you get blockage of any kind of release from the sinuses, and that's when you get chronic sinusitis. You want to open them up with intranasal corticosteroids and also nasal saline lavage. All right, so let's move on to some questions. All right, so the first question is, 28-year-old woman has had eczema since she was a child. She complains of a dry, scaly, and very pruritic rash on her antecubital fossa despite using emollients. What is the most appropriate next step? Is it A, start oral corticosteroid, B, start topical corticosteroid, C, start pimecrolimus, D, start tacrolimus, or E, start oral antihistamine? And go ahead and put in your responses. Good. 78% of you got it correct. It is start topical corticosteroid. Right? That is the first-line therapy for eczema. All right, so B is the correct answer. Very good. All right, next question. A 42-year-old woman reports runny nose, sneezing, and itchy nose occurring every April. She has carpets in the home and has 2 dogs. Symptoms last for about 8 weeks. It's a 42-year-old man. He denies symptoms during other times of the year. Which of the following allergens is the most likely cause of his symptoms? Is it A, dog dander, B, tree pollen, C, grass pollen, D, weed pollen, or E, dust mites? Go ahead and respond. Very good. Tree pollen. You guys are really good. That's great. Y'all should be allergists. Okay. That is the correct answer. It's in April. It's during the spring. That's when trees really start to pollinate. and that coincides with his symptoms, so therefore the allergen is the tree pollen. Very good. All right, next question. A 45-year-old woman develops linear vesicles and blisters 3 days after going hiking on a forest trail. Her reaction is most likely categorized by which type of hypersensitivity reaction? Is it A, type 1, B, type 2, C, type 3, or D, type 4? Go ahead and put in your response. Very good. Vast majority, 73%, answered it correctly. It's a type 4 delayed reaction. Remember, the timing is really important. 48 to 72 hours after the initial trigger, it's when they have the reaction. It's type 4 is the correct answer. Next question. 45-year-old man with a history of peanut allergy developed shortness of breath and abdominal pain after accidentally eating a cookie containing peanuts. His blood pressure is 130/80 and heart rate is 110 beats per minute. On exam, there are audible wheezes. Skin exam is normal. What is the most appropriate next step? Is it A, albuterol, B, diphenhydramine, C, solumedrol, D, epinephrine, or E, observation only? Go ahead and enter your responses. Very good, 99%. You guys are awesome. You guys are going to ace this test. And I specifically wrote this question because of two things. One is that this patient did not have any, the answer is D, epinephrine, first-line therapy for anaphylaxis. The patient did not have any cutaneous symptoms. So you can't rule out anaphylaxis just because of a lack of cutaneous symptoms. And two, the patient did not have hypotension, right? So this patient had anaphylaxis because of two organ involvement, and the correct treatment is with epinephrine. And 99% of you got it right, so great job. The other 1% probably pressed the wrong thing. All right, so next question. 35-year-old man complains of purulent rhinorrhea, sinus headache, and cough for the past 2 days. His children are also sick at home. He's afebrile. What is the most appropriate next step? Is it A, order allergy testing, B, prescribe amoxicillin, C, prescribe oral corticosteroid, D, prescribe topical decongestant, or E, reassurance only? Go ahead and put in your answers. Very good. That is the correct answer. E, reassurance only. This patient has a viral, rhinosinusitis. Antibiotics are not indicated. Topical decongestants are not indicated because they can lead to rhinitis medicamentosa. The correct answer is reassurance only. All right. We're going to talk about asthma. I'm not going to talk too much in depth about asthma because you're going to have a lot of it in the pulmonary section. But remember, asthma is a chronic inflammatory disorder of the airways, and it's characterized by reversible airflow obstruction, cough, wheeze, chest tightness, and shortness of breath, okay? And the way you want to think about asthma is by the rule of twos. It's easy to remember, right? So there's two components of asthma control, impairment and risk. And impairment is basically symptom frequency. Do they have symptoms more than 2 times per week, or more than 2 nightly symptoms per month? Or do they need their rescue inhaler, albuterol, more than 2 times per week? Risk is how many times they've been to the emergency room. So if they've had more than 2 emergency room visits or hospitalizations, that means that their asthma is not under good control. Okay. So there's a lot of different relievers and controllers. The gold standard is really inhaled corticosteroids. If they can't tolerate that, alternatives include leukotriene receptor antagonist and also 5-lipoxygenase inhibitors like xylutin. And then there's long-acting beta agonists, which always, always, always should be used with an inhaled corticosteroid, because if you use it alone, you actually increase risk of adverse effects if you use it alone. So they always should be used in combination with inhaled corticosteroids. And then finally, there's long-acting muscarinic antagonists as well too. Right. There are new biologics that are underway, omalizumab, mepolizumab, and dupilumab as well too. Very fascinating. They're able to target specific mechanisms where asthma is triggered, IG, for example, IL-5, IL-4, and IL-13. So very interesting. Right. So remember, when you have a patient who has uncontrolled asthma, you should step up therapy. So if they're already on a low-dose inhaled corticosteroid, you need to step up therapy to either a medium-dose inhaled corticosteroid or add on a long-acting beta agonist for these patients. Okay. If they're overusing their albuterol, same thing. If they're uncontrolled, having more than 2 daily symptoms per week, more than 2 nightly symptoms per month, or using their rescue inhaler more than 2 times per week, that means they are having uncontrolled asthma and you need to step up their therapy. Okay. Right, drug reactions. The World Health Organization describes any adverse drug reactions as any noxious, unintended, undesired effect of a drug that occurs at doses used for prevention, diagnosis, or treatment. So cutaneous reactions are most common. About 15% of patients have adverse drug reactions during the hospitalization, and about 7% experience serious reactions. So there's a lot of different types of adverse drug reactions. The one that I'm going to most focus on, obviously, are the allergic types. And again, we go back into the Jelen-Coombs classification of your type 1, type 2, type 3, and type 4. Okay? So again, type 1 drug reactions, immediate, all right, minutes to hours. Again, when I get a consultation with them, the ED, I ask them, how long after the patient started this medication did they develop the reaction? Okay, what kind of symptoms did they get? So the reactions that these patients for type 1 drug reactions are going to have, they're going to have, urticaria, angioedema, anaphylaxis, for example. And penicillin is notorious. It's one of the most common causes of type 1 immediate drug reactions. Now, because it's so common, let's spend a few moments talking about it. Now, a lot of times we think, cephalosporin and penicillin, patients with penicillin allergy, you shouldn't give cephalosporin, okay? Now, we're finding out more and more that that's not necessarily true, okay? The cross-reactivity rate of penicillin with cephalosporin is only about 1 to 3%. Okay, so it's very, very low. So that could just mean that, just because the patient is allergic to penicillin, it's just because of their allergic nature that they're also allergic to cephalosporin, rather than having any real cross-reactivity. So it's actually safe to give cephalosporin to patients who are penicillin allergic. Okay. Now, when do you do desensitization for patients with penicillin allergy? Well, there's certain criteria. If the patient has, for example, neurosyphilis, conditions where penicillin is the only and most effective treatment, that's when you want to use it. Another example would be a pregnant woman with syphilis, okay, because that's the most effective treatment. And then finally, if you've got a patient who has multi-drug resistant organism and penicillin is the only thing that they're susceptible to, then that's when you would do desensitization. So what is drug desensitization? What it is a temporary state of tolerance, okay? And it's necessary if the drug is the only available effective therapy, again, neurosyphilis, pregnant woman with syphilis. And what we do is we kind of have a mild grade systemic reaction. And what that means is, remember I talked about those mast cells and all those mediators kind of degranulate and come out. What we do is we have kind of a stained, low grade allergic reaction so that the patient can actually tolerate the penicillin or any kind of other drug. So we start really slow introduction of increasing amounts of that particular drug. The first amount or dose is usually about 1 to 10,000 or 100,000 of the full dose. And you start increasing the dose every 15 minutes. And it usually is a long procedure. It takes about 4 to 8 hours to do the procedure. And it's only useful for IG-mediated drug reactions. So you can't use it for non-IG-mediated reactions like Stevens-Johnson syndrome or TN or DRESS syndrome. Those things are actually contraindicated. You don't want to do drug desensitization for those types of things. The other thing to keep in mind is that once you do the drug desensitization, those patients have to take that drug every single day to maintain that state of tolerance. It's not like you do the drug desensitization and the patient's cured and they can take penicillin whenever they want. No, it doesn't work that way, right? Because it's only a temporary state of tolerance if the patient is taking that drug every single day. So if you've got a patient who has a, whatever indication for it, like let's say pregnant woman with syphilis, you do the drug desensitization, then that patient has to continue to take that drug, the penicillin, until they're finished with their treatment. And when they stop, if they have any lapse in their treatment course, they got to redo the whole entire drug desensitization procedure again. It doesn't mean that you're cured of it. It's a temporary state of tolerance. Okay? That's a key concept. Now, your type 2 drug reactions, these are cytotoxic reactions. It occurs when you have IgM or IgG antibodies that bind to drug antigen on cell membranes. The antibody-coated cell surfaces are cleared by monocyte macrophage system. So examples of this include drug-induced hemolytic anemia and also thrombocytopenia. Drugs that do this include methodopa, penicillin, and also cephalosporins as well. Type 3 reactions occur, again, 1 to 3 weeks, okay, after the suspect drug. It's immune complex mediated, so these immune complexes start forming in the body. They deposit in the blood vessel, causing the vasculitis that you see. They also can deposit in the kidneys, so you get glomerulonephritis, you get lymphadenopathy, you can get arthritis as well too. Examples of this include serum sickness from ATG, thorough urocells, and also phenoltonin as well too. Next, you have your type 4 reaction. Again, this occurs 48 to 72 hours. It's a delayed T-cell mediated reaction, okay? An example of this include your contact dermatitis from like neomycin, local anesthetics, and topical antihistamines, okay? So the timing is really, really important to figure out what type of drug reaction it is. Now, there are some things that don't fall into the Jelen-Coombs classification. All right, one of them is vancomycin hypersensitivity, also known as red man syndrome or red person syndrome. So these patients get, the pruritus, the flushing, the erythroderma, and it's really secondary to non-specific histamine release. That's rate dependent on the vancomycin infusion. So the severity correlates with the amount of histamine that's being released. Has nothing to do with the vancomycin levels. It's just all about the rate of infusion. So what you do to treat is you actually reduce the vancomycin infusion rate, and you actually can pre-medicate these medications with histamine antagonist. DRESS syndrome stands for drug reaction eosinophilia with systemic symptoms. Common culprits include your aromatic anticonvulsants, so sulfonamides and allopurinol are common ones. It's associated with human herpes virus 6 infection or reactivation. Treatment is you stop the offending drug, obviously, and you also can give them glucocorticosteroids plus or minus IVIG. Serum sickness appears 1 to 3 weeks after administration of a drug. Clinically, they'll have fevers, rashes, joint pain, lymphadenopathy, muscle aches, proteinuria, kind of have these kind of universal skin findings, this classic serpiginous rash on the hands and feet, but they can also have itchiness, redness, urticaria, angioedema as well too. They get arthralgias, remember, immune complex deposition in the joint spaces. And they can also get GI symptoms as well too, which include nausea and vomiting. Some common causes include equine anti-tetanus, antibiotics like cefaclor, penicillin, other things like ATG, OKT3, monoclonal antibodies, and also venom stings as well too from bees and wasps. Radiocontrast media reactions are non-IgE mediated, so they cause direct mast cell degranulation. It is not associated with seafood or iodine. That is a complete myth. I hear that all the time. Our radiology department calls me about this patient who has a supposed seafood allergy or iodine allergy. Can they get CT with contrast? Yes, they can. There's no association with radio contrast allergy or getting a CT scan for a patient with seafood or iodine allergy. Okay? What are the real risk factors? Well, some risk factors include being female, having asthma, a prior reaction to radio contrast, and also cardiovascular disease. But seafood allergy or iodine allergy are not one of them. What do you do for these patients? Well, you ask the radiology department to administer non-ionic or hypoosmotic radio contrast. You can pre-medicate the patient as well, too. So you give them prednisone, 50 milligrams, 13 hours, 7 hours, and 1 hour prior to their procedure. And also diphenhydramine 1 hour prior to their procedure. You can give albuterol or ranitidine as needed. Insect allergy. Most common causes are from the Hymenoptera order. These include bees, yellow jackets, hornets, wasps, and ants. Now remember, large local reactions, a patient says they got a bump after being stung by a bee, you don't need any further workup. The only time that a patient needs workup is if they've had anaphylaxis to a venom sting. Venom immunotherapy is very effective. It's 98% effective in preventing future systemic reaction to stings. So why is it that only patients of anaphylaxis need any further workup? This is a nice study that was done by Golden et al. And what they showed was if you've had no reaction whatsoever, you've never had a sting in your whole entire life. If you get stung within the next 10 years, your risk of a future reaction is only 17%. Okay? If you've had a large local reaction, your future risk of a systemic reaction in the next 10 years is only 10%. So if you had a local reaction, you're actually less likely to get a systemic reaction than the next guy who has never had a reaction, right? If you've had a cutaneous systemic reaction, and then it's about 20%. So you can argue, and it's debatable, whether adults with cutaneous, like generalized hives, should have any further evaluation on 20% versus 17%, which is the general population. But definitely if someone's had anaphylaxis, then you've got about a 60% chance of a future reaction within the next 10 years if you're stung again by a sting. Okay, does that sort of make sense? No? Okay. All right, food allergies. All right, it affects about 1 in 5% of adults. It's a leading cause of anaphylaxis outside of hospitals. You got the most common are soy, nuts, and seafood. Okay, for children, it's more wheat, eggs, milk. Okay, but those children tend to outgrow those things, so the ones that are left over carry on into adulthood, and that's soy, nuts, and also seafood. How do you make the diagnosis? It's a history and physical. Remember, it's IG mediated, so when they eat the food, it's within minutes to 2 hours after eating the food, they have reactions. I get this all the time where patients tell me, oh, I ate a particular food. The next day, I started having symptoms. No, that's not a food allergy. It's something else. I don't know what it is, but it's something else, okay? It's not a food allergy, okay? So you don't need to do anything for those patients. All you do tell them is this kind of reassurance. It cannot be a food allergy. But you want to elicit the right history, right? Because remember, there's also that late reaction. So you want to tell them, what's your first symptom? If they tell you, okay, within minutes I got itchy, but the hives didn't occur until about 8 hours later, that still can be a type 1 mediated reaction because their first reaction is pruritus, right? It's within minutes, but then they start having more symptoms because later on you have that late phase reaction and you've got recruitment, and then you get the hives 8 to 10 hours later. That could still be a food allergy. But if they're just telling you, I ate it in the morning, I was fine the entire day, all of a sudden I woke up in the morning and I broke out in hives, that's not going to be a food allergy. Okay. Now, in terms of testing, now the thing about skin testing is that it has a great negative predictive value. That means if it's negative, that's great. You're not likely to be allergic to that food. However, we have a very high false positive rate. It has a very low specificity, about 50%. So if I tested you guys in this room, I think about probably half of you or 25% of you would have something positive that would show up. And it would clinically mean absolutely nothing, all right? So that's why the history is so important. And you only test after being guided by what the clinical history tells you, okay? All right. Now in terms of allergy blood testing called RAS testing, it's less sensitive than skin testing, but it does have certain cutoffs that are kind of clinically useful in terms of the positive predictive value, and I'll show you this right here. So for example, if you test some patient and their peanut level is like 20 above the 14 level, then they're about 100% of having a clinical reactivity. So there's certain foods that these things are very helpful, A lot of other foods, we don't have these cutoff values, and it's not that useful. So you have to really go with the clinical history. That's really, really important. Again, with everything you do in medicine. All right. Diagnosis, the gold standard is the double-blind, placebo-controlled food challenge. That's probably used in like research arenas and stuff like that. Generally, I just do an open oral challenge if it's not very clear whether they truly have a food allergy or not. Treatment is with avoidance, and you want to give epinephrine auto-injectors for patients at high risk. So patients who have like peanut allergy, for example, shellfish allergy, epinephrine, and have a history of anaphylaxis, epinephrine auto-injectors are indicated just because of the high risk of fatality. Oral allergy syndrome, this occurs when you get localized reactions to raw fruits and vegetables. So essentially it's a localized food allergy syndrome, and the symptoms are really just confined to the lips, the mouth, and the throat. They get also, tingling, itchiness of the lips, roof of the mouth, and the throat. But they can tolerate cooked fruits and vegetables, right? So I consider kind of a mild localized food allergy syndrome. Immunodeficiencies, right? So think about immunodeficiency in patients who had multiple recurrent infections or opportunistic infections, okay? Although primary immunodeficiencies are found mostly in children, we're seeing them more in adults because these kids are actually growing up and they're becoming adults, and so probably you guys will see them in your primary care offices. And then also there are certain things that actually are diagnosed in adulthood. So we'll go over some of them, all right? So when should you suspect primary immunodeficiency? If your patients have had any 2 or more of the following, if they had more than 4 infections in a year, 2 serious sinus infections a year, and I'm talking about true, real sinus infections, not the viral stuff that we talked about before, but real sinus infections. Guys, I got fever, 104, and got mucopurulent discharge, all that stuff. That's a real bacterial sinus infection, not the viral stuff. If the patient has needed antibiotics for more than 2 months in a year with little effect, they've got more than 2 pneumonias in a year, failure to thrive, deep organ abscesses, persistent thrush, need for IV antibiotics to clear infections, 2 or more deep-seated infections, and also a family history of primary immunodeficiency because a lot of these things are autosomal recessive. So the first one we'll talk about is congenital agammaglobulinemia or Bruton's agammaglobulinemia. And what happens is these patients have a mutation in the Bruton tyrosine kinase. So you have a arrest of your B cells. Your B cells are responsible for making antibodies. So when these B cells are kind of stuck in this age, they can't make antibodies, and you get recurrent sinopulmonary infections because you have no antibodies to protect yourself. So these patients are exquisitely susceptible to encapsulated organisms, Staphylococcus, Streptococcus, Meningococcus, Haemophilus, and they're also susceptible to enteroviral infection and Giardia infections as well too. So how do you make the diagnosis? These patients have no antibodies, they've got no B cells, and you treat them with exogenous antibodies, so IVIG or sub-Q IG, and you also give them prophylactic antibiotics as needed. Common variable immunodeficiency is similar, but it's a failure of B cell maturation into plasma cells. So these patients will kind of get the same sinopulmonary infections as agammaglobulinemia patients, but because they make some antibodies, they also have increased risk of autoimmune disease and malignancy. So some of you in the room may be wondering, well, these are immunodeficiencies, and I thought autoimmune disease was when you have an overaggressive immune system. How can you have, autoimmune disease in a patient that has an immune deficiency? Well, the reason why you have it is you have an immune system that is not working properly, okay? So it's not able to clear up infections appropriately. So you have this ongoing inflammation that occurs. The body gets confused. It starts to attack its own organs because there's always ongoing infection, ongoing inflammation. And that's why you have this kind of duality of both an immunodeficiency state and also autoimmune disease. So these patients of common viral immune deficiency will have increased risk of, Hashimoto's, thyroiditis, celiac disease. They'll also have increased risk of lupus, rheumatoid arthritis as well too. How do you make the diagnosis for common variable immunodeficiency? These patients will have low levels of IgG and IgA and IgM, and also low levels of B cells as well too. Treatment is the same. You give exogenous antibodies. IgA deficiency is very, very common. A lot of you will see this. It occurs in about 1 in 300 people. Most people, vast majority of people, are asymptomatic. And for those that are symptomatic, they'll have like kind of mild symptoms, prolonged or recurrent upper respiratory infections, maybe giardiasis, but there is an increased risk of autoimmune disease like celiac disease and thyroid disease. Diagnosis is undetectable IgA, so it's not like if you have like IgA of 30, then that's considered IgA deficient. You have to have IgA that's undetectable, less than 7 is usually the laboratory standard, okay? Usually they don't require any treatment. For those who do have symptoms, we give them prophylactic antibiotics. You can't give IVIG because IVIG doesn't have any IgA in it, so it doesn't treat that. So you just give them prophylactic antibiotics. Complement deficiencies, you've got early complement deficiency and terminal complement deficiency. With early complement, these patients have pyogenic infections, increased risk of autoimmune disease. With your terminal complement deficiency, they get recurrent Neisseria meningitis. Okay, so if you have a patient who's admitted to hospital for multiple bouts of Neisseria meningitis, think about terminal complement deficiency. Diagnosis, you want to screen with a CH50, and if it's undetectable, then you can look at individual complement factors. Treatment is with prophylactic antibiotics and also immunizing patients to, again, like Neisseria meningitis. So, some high-yield pearls. I think I've talked about this ad nauseum already. Anaphylaxis can occur with cutaneous manifestations, and it can occur without hypotension. So, recognize anaphylaxis early and treat with epinephrine. One thing to keep in mind, there's a difference between subcutaneous dose and IV doses of epinephrine. Don't confuse the two. Epinephrine, 0.2 to 0.5 milligrams intramuscularly is first-line treatment for anaphylaxis. That's the key high-yield pearls. All right, we're already past time, but you guys want to do questions? Yeah, all right, let's do some questions. All right. It's question number 6. A 24-year-old woman with asthma reports having cough 3 days per week, for which she uses albuterol with relief. She has 3 nighttime awakenings per month because of difficulty breathing. She is currently on a low-dose inhaled corticosteroid and reports adherence to her medications. What is the most appropriate next step? Do we, A, recommend continuing low-dose inhaled corticosteroid, B, discontinue low-dose inhaled corticosteroid and use albuterol only as needed, C, change to medium-dose inhaled corticosteroid, or D, add leukotriene receptor antagonist and continue low-dose inhaled corticosteroid? Go ahead and put in your answers. Very good. 70% answered it correctly. You want to change to a medium-dose inhaled corticosteroid. Now, I noticed some of you put D as the answer. Now, why is D incorrect? The reason why D is incorrect is it's not the preferred choice, right? Your preferred choice is you want to go to a medium-dose inhaled corticosteroid. Alternative, if the patient declines or whatever, then you can add a leukotriene receptor antagonist, only if the patient refuses. But the optimal choice is C, change to a medium-dose inhaled corticosteroid. Next question. Drug desensitization allows for a temporary state of tolerance. Which of the following would be an indication for drug desensitization? Is it A, cephalosporin-induced Stevens-Johnson syndrome, B, history of toxic epidermal necrolysis, C, epilepsy and a history of DRESS syndrome, D, pregnant woman with history of contact dermatitis due to neomycin, or E, neurosyphilis and a history of penicillin anaphylaxis? Go ahead and put in your answer choices. Very good. 99% got it right. Neurosyphilis and history of penicillin anaphylaxis. That's correct. All right. Next question. 25-year-old woman develops rash, fever, arthralgia, and lymphadenopathy 3 weeks after starting Cefaclor for a urinary tract infection. Her reaction is most likely categorized by which type of hypersensitivity reaction? Is it A, type 1, B, type 2, C, type 3, or D, type 4? Go ahead and put in your answer choice. Very good. 82% correct. The correct answer is C. It is type 3. Remember, immune complex reaction occurs weeks after onset of the culprit drug, and you have all these symptoms of immune complex deposition. C is the correct answer, type 3 hypersensitivity reaction. Good. Question 9. A 28-year-old pregnant woman in her last trimester complains of nasal congestion that keeps her up at night and affects her quality of life. Which of the following is the most appropriate next step? Is it A, prescribe intranasal budesonide, B, prescribe oral budesonide, C, prescribe intranasal decongestant, D, prescribe oral decongestant, or E, refer to an allergist for skin testing? A, very good. That is the correct answer. Prescribe intranasal budesonide. Although I would really love the allergy referral for skin testing, it's not indicated, unfortunately. A is the correct answer. It's class B in pregnancy. That's what you want to try first. Very good. Okay. Next question. 68-year-old woman has had daily hives for the past 8 weeks. Lesions last less than 24 hours but reappear in a different location. She denies any fevers, arthritis, or weight loss. Which of the following is the most appropriate next step? Is it A, prescribe topical corticosteroids, B, prescribe non-sedating antihistamines, C, prescribe sedating antihistamines, D, measure C1 inhibitor levels, or E, refer to a dermatologist for skin biopsy? Go ahead and put in your answer choice. Very good. 71% got it right. The answer is B. Now remember, this case is a patient with chronic urticaria. This patient does not have any red flags, so no fevers, no arthritis, no weight loss, lesions last less than 24 hours, and this treatment of choice is non-sedating antihistamines. She's elderly. You don't want to give her sedating antihistamines because of anticholinergic effects. And that's it. Thank you very much, and good luck, you guys.